Welcome to the Researched RN podcast. I am your host, Steven Cuzmenco. In this podcast, I discuss new and interesting peer-reviewed research articles from various nursing researchers and other professional publications. In this second episode, we'll discuss an article published in Heart and Lung, the Journal of Acute and Critical Care, titled A Family Intervention to Prevent Post-Operative Delirium in Patients Undergoing Cardiac Valve Surgery, a Randomized Control Trial. It's authored by Lin and colleagues. So to get into the background of this article, disorders or diseases of the heart valves are a common cause of cardiovascular disease in China as well as the United States. But this article focused on Chinese population. Surgical repair of diseased heart valves is becoming more common, mainly driven by an aging population. Surgery is a great option, but there are lots of post-op complications, and one of those being delirium, which can occur in as many as 33 to 56% of patients undergoing surgical valvular repair. Delirium increases hospital length of stay, increases mechanical ventilation time, increases healthcare costs, and it exacerbates the need potentially for long-term care after hospitalization. Patient delirium has also been associated with depressive and anxious feelings in family caregivers. With delirium, prevention is key, and if you have experience with caring for patients with delirium, it can be very challenging. It's going to test your patience, but it's very important to prevent it because treating it is just that much more challenging. And so as the title of this article states, the author sought to determine the degree to which a family intervention can prevent post-operative delirium in patients receiving cardiac valve surgery. So family visits are not very well supported in Chinese hospitals, primarily due to security concerns, even though evidence supports its use. Another concern is that more family presence in the ICU can lead to more infection, which is not the case according to published literature. Family engagement or family presence in the immediate post-op or ICU setting has been associated with a reduced risk of developing delirium by assisting with orientation, cognitive stimulation, and sensory checks. Some studies also reported increased satisfaction in ICU patients when the family is present, which is not that surprising. If I'm ill and hospitalized, I want to be able to see a familiar face too. And research in preventing delirium in cardiac valve repair surgery is lacking. So these researchers used the family integrated care theory to develop a family intervention. They hypothesized that family interventions would reduce incidence of delirium in patients receiving heart valve surgery, and they thought that the interventions done by family members would have a bigger impact than the interventions implemented by the care team or the ICU nurses. The research team consisted of one chief physician, one attending physician, and one head nurse, 6 additional ICU nurses, and there was one researcher involved in the team. The team received extensive education on the protocol, the family interventions, as they were directly involved in the implementation and evaluation, which I'll talk more about here shortly. The design of this study was a 2-group, single-blind, randomized controlled study in a cardiovascular surgical ICU in the Fujian Medical University Union Hospital, a 2,500-bed tertiary care teaching hospital in China. That's a huge hospital, 2,500 beds. And specifically, there was a 38-bed cardiovascular surgical ICU that was spread across 2 floors and staffed by 100 nurses. There were 2 inclusion criteria for family caregivers or research study participants. The first one is that the patient had to be over the age of 18, and the family caregivers had to also be over the age of 18, and they had the ability to visit daily. 6 exclusion criteria for patients existed. Patients were not included if they self-reported alcoholism or drug abuse, if they were found to have severe audiovisual loss based on physical exam, if they were in a coma or had deep sedation, if they had delirium at the time of admission, if they had a psychiatric disorder based on medical history review, or any previous diagnosis of neurological conditions like dementia or stroke, also based on medical history review. The researchers were creative in minimizing the likelihood of contamination of the sample. So the cardiovascular surgical ICU was spread across 2 floors, and there were 3 cardiac surgical units where patients from the ICU could be transferred. Participants were transferred to the different floors of the cardiovascular surgical ICU after surgery. So it didn't matter which of the floors they went to. There wasn't really any control there, which is good to minimize potential bias. But for the 3 other step-down units, so to speak, they randomly selected 2 out of the 3, where one would receive all the participants of the control group and the other all the participants in the intervention group. Of course, the patient couldn't be blinded to which group they were in, nor the family, because they were the ones getting the interventions that were not normally in place. So the members of the research team that analyzed the outcome data, they were blinded to which data they were analyzing, whether it was from the control group or the intervention group. After surgery, both groups received the same degree of ICU care with regard to sedation, analgesia, and mechanical ventilation by the intensivist caring for them. The control group received normal visitation, which meant that the family could visit twice a day for 30 minutes between 8 and 8:30 and 4 and 4:30. During this time, family was typically updated by the physician and the ICU nurse, and their questions were answered, but no other tasks or training was provided. The experimental group received the same amount of time, so 60 minutes of visitation time, same as the control group, but they received detailed education on the delirium prevention interventions provided by videos, handouts, and this was all information developed by the research team, and also real-time education provided by the ICU nurses that were part of the research team. In order to prep the family for the interventions that they would be providing, they were trained on all things about the ICU. So, of course, prevention efforts for delirium, but also infection prevention strategies or efforts, and then information of the general ICU environment. Before the family could perform the interventions, they were asked to return, demonstrate each intervention that they would be providing, such as ways to promote psychological care, orienting mental status using the 5W1H reorientation strategy, cognitive stimulation, preventing sensory deprivation, and participating in ICU life, aka ADLs, and hygiene. The ICU nurse was present during all the visits to prompt the family and provide further instructions if they needed it during their visit with their loved one. And these training sessions also involved one-on-one sessions with the ICU nurse. So the family caregivers were trained pretty extensively prior to the surgery, and even during the interventions, they were coached. So very good involvement by the research team to ensure that the interventions were provided well and effectively. The intervention period started on post-op day 1 and lasted until ICU transfer, or a maximum of 7 days. And family members were given feedback on the completeness of their interventions by the research team after they had provided them. The research team also helped them through any problems that they faced. So finally getting into what they measured. So demographics of patients and family caregivers were collected, as well as an acute physiology and chronic health evaluation score, otherwise known as APACHE score. The primary outcome of this study was the incidence of delirium in the first 7 days post-operative, measured using the CAM-ICU, or Confusion Assessment Method Intensive Care Unit. For any listeners that aren't familiar with the CAM-ICU, this assessment looks at 4 patient characteristics. The first one being acute changes in mental status, the second one being inattention, and the third being disorganized or incoherent thinking, and finally the fourth being altered concentration of consciousness. And to be considered positive, the characteristics 1 and 2 and either 3 or 4 must be present. The delirium assessments were performed by ICU nurses not involved in the daily care of the patients 3 times a day at 8 a.m., 2 p.m., and 8 p.m., and upon any mental fluctuations. A Richmond Agitation Sedation Scale, or RASS score, above -4 was required before the ICU nurse would move on to perform the CAM ICU delirium assessment. And incidence of post-op delirium was defined by the research team as having one positive CAM ICU during the 7-day intervention period. The secondary outcomes looked at both patients and family caregivers. The secondary outcomes for patients were timing of first episode of delirium, the duration of mechanical ventilation time, and length of ICU stay. And the secondary outcome measures for family caregivers were anxiety, depression, and overall satisfaction. And so moving on to the results, the study period was between May 2021 and October 2021. 110 patients that received heart valve surgery were approached for the study. 19 did not meet inclusion criteria. 7 refused to participate, leaving 84 participants. And from this group, 80 completed the study and were included in the results, 40 in the control group, 40 in the intervention group. Over half of the participants underwent valve surgery replacement alone, and about a third of them received valve replacement and repair. The average age of the patients was 61, give or take 7.5 years. Most were male, and no differences were reported in the participant age, gender, education, or clinical characteristics such as type of surgery, OR time, or Apache score. And for the caregivers, the average age was 43, give or take 10 years. Nearly half were female. Most had a junior or high school education, and the majority of caregivers were either the children or spouses of the patient. And there was no statistically significant difference in age, gender, education, marital status, address, occupation, income, or relationship to the patient. The visits ranged from 3 to 10 in that 7-day period, with most patients in both groups getting 3 or 4 visits. The average number of family visits in the intervention group was 4.15 and control group 4.55. The incidence of delirium in the intervention group was 7.5% and the control group 27.5%. So a huge reduction in the incidence of delirium between the control and the intervention group. The timing of the first episode of delirium was later in the experimental group, but this was not statistically significant. The average length of stay in the ICU was measured in hours. And so for the intervention group, this was 45.75 hours. And in the control group, this was 66.5 hours. And there were no differences in length of time for mechanical ventilation, which isn't really something that this intervention, in my opinion, could have fixed or reduced. Anxiety and depression occurred less in family caregivers within the intervention group compared to the control group, and caregiver satisfaction was higher in the intervention group. There were no complications such as unplanned extubation, ICU-acquired infections, or abnormal vital signs during the intervention. And so moving on to the discussion, delirium in the ICU leads to many complications, and prevention is key. This study successfully demonstrated that family intervention reduced incidence of delirium and shortened hospital length of stay. Sensory deprivation is related to delirium, and the authors noted that family will know how to use the hearing aids and visual aids best to maximize the likelihood that the patients will not only have the sensory aid on, but will have it functioning appropriately. I know in my training as an ICU nurse, I really didn't understand how hearing aid works. Of course, glasses, but oftentimes when we're assessing our patients, we just take the glasses off and we may not put them back on. Also, the familiar face of the family members provided emotional stability when orienting the patient, and I can see that being the case. The ICU stay was shorter in the intervention group, and so the authors say that this might be because they were able to spend more time asking questions about the condition, the prognosis, and the treatment plan. And patients' mental health could have benefited from this because the information about their condition came from a family member who understood their condition better, in which case it could have helped the patient cope with their condition, and better coping enhances compliance to treatment. And that is what they think led to less time in the ICU. The benefit seen in family caregivers was less anxiety and depression. So they say that maybe this was because they were more aware of the patient's condition. Of course, information about our loved ones when they're hospitalized is important as family members or friends, loved ones, acquaintances, whatever it may be. So if you know someone who's hospitalized and you don't know or understand what's going on, that could increase your stress response, and that could lead to depression, anxiety, or insomnia. And if you're depressed, anxious, and you haven't been sleeping, that might hinder your willingness or ability to provide delirium prevention care or just participate in their care in an effective manner. So the sharing of information between the family caregiver and the care team improves satisfaction, but also the delirium interventions themselves, because the families developed a sense of usefulness, competence, and self-worth as they were able to make a direct contribution to their loved one's recovery after critical illness. As I mentioned earlier, there was no infections or unplanned extubations recorded during the intervention, and this is probably a result of the detailed education that they provided to the family prior to receiving the delirium training. Some of the limitations: this was a single center study, which limits generalizability. This was a small sample size, and data collection was limited to the hospital stay. So we're not really sure if there's any benefit that extends beyond discharge and into home life. The authors also mentioned that they could have benefited from qualitative data such as interviews or focus groups, which could have given them more insight into the feelings, thoughts, and opinions that are not always clearly measurable with quantitative surveys. Care of the family members should become and remain the focus of clinical nurses. Involvement in care should be appropriate for the family member. We don't want to ask a family member to do something that they are not comfortable doing before, of course, orienting them or giving them some kind of guidance, as these researchers did in this study. Future research, they say, should focus on standardizing educational content provided to family members on delirium prevention, and we need to pay more attention to the role of the family caregivers in delirium prevention. So I'd really encourage you to read this article and look at the main aspects of delirium prevention education provided to family members that you encounter at your workplace. I'm sure you know delirium prevention is much easier than delirium treatment. So we want to do everything we can to prevent delirium from happening in the first place. So I really hope you enjoyed this discussion, this audio summary of this article. That concludes the second episode of the Researched RN podcast, your virtual journal club on the go. Once again, I am your host, Steven Cuzmenco. You can email me at researchedrnpodcast@gmail.com with any articles or feedback about this. Thanks.